Everyone, really happy to be here.
We actually met you for the first time at one of our virtual meetings with Ron. So thank you again, Ron, for connecting us with you. But the quote is by Richard Strauss: "The human voice is the most beautiful instrument of all, but the most difficult to play." So what is it about the human voice that is so special?
People that I know in medicine, I remember being in med school and I had a really nice teacher said, you don't realize you have an organ until you have a problem with it, right? So you don't know you have a liver unless you have problems with your liver. You don't realize you have a stomach until your stomach hurts. And you don't value the importance of voice until your voice changes. People really take it for granted. When we start having voice changing, I mean, it's all our identity, the way we communicate with others, the way we're perceived by others, that changes. And I can tell you that most of my voice patients, I would say about 50% will cry the first time I meet them. Okay. In my office, I mean, within 30 seconds, right, Dr. Abdelhadi? And because it's our identity, it's the way we communicate, it's how people know who we are. And there's this really nice, I don't know if you guys watch Netflix. There's this really stupid show where they have to get married based on the sound of their voice. Is that Love is Blind? I mean, I watch it. They have to get married, but they can never see each other. So they go on like blind dates and there's a wall and then they have to talk. And really it's the sound of their, you fall in love with somebody else's voice, which is really interesting. So knowing that you have a voice disorder, imagine how handicapping this would be, right? To go on a show like this. So that's why I love this quote so much.
And so can you talk a little bit about how you got into voice? Because you've had quite a varied career and that got you here to USF.
Yes. So I had a problem with my voice. I was a singer when I was younger and I was 15 and I wanted to be a professional singer. And I was training and my voice coach told me something's wrong with your voice. You need to see a laryngologist. So it was cracking. I wasn't able to get through my shows. Was 15, so I was, very distressed by that, obviously, as a young teenager. And I went to see a laryngologist. She diagnosed me with vocal cord nodules that are little lesions on the vocal cords. And then I met a speech pathologist, and she told me, listen, you have to take this seriously, or else you're not going to be able to sing anymore. And then I did 6 months of voice therapy, speech therapy. I was really a good student. And thanks to the both of them and my singing coach together, I was able to have a career after that. So then after that, until 23, I was a professional singer. And I was always so grateful to that team of multidisciplinary people. So my speech pathologist, my laryngologist, and my voice coach working together. And I kind of owe them a lot of what happened to me in my life after. And I know a lot of people who don't value voice care, that don't take care of their voice, and they go see doctors and then they don't follow, they just don't do what they're supposed to do. And today they can't sing anymore or they can speak anymore. So that was always, when I was young and I went into med school, they told me, what do you want to do? I said, well, when I grow up, I want to have a multidisciplinary voice clinic. And they all laughed and they're like, sure, you're super young, it'll change, And then I went to residency interview and they said, why do you want to be an ENT? I said, because I want to have a multidisciplinary voice clinic. And here I am today. So I feel really grateful to have that multidisciplinary voice clinic.
And you were also trained as an SLP too.
Oh, correct. Yeah. So I went to, I didn't get into med school the first time, right? So I actually went to train as an SLP first. And then that really helped me because that's how I learned a lot of what I know today. And I had all this background.
And now, interestingly, you're also a clinician researcher. And one of the things that we were here, the organization Dysphonia International was here earlier in Tampa for the Bridge to AI conference. And so can you talk a little bit about the Bridge to AI conference and also what is voice as a biomarker?
Yes.
I know we've mentioned that a few times, but I don't know if everyone understands what that really means.
So voice as a biomarker means that there are cues in your voice that give information on your health, right? So actually laryngeal dystonia is one of the easiest one to recognize. If you go to an emergency department and people don't know about your disease, they won't know. But if you go to any of the speech pathologists or the laryngologists who are trained, within 5 seconds of hearing your voice, we can give you a diagnosis. And there's a lot of voice biomarkers apart from laryngeal dystonia that can give a lot of information. Patients with Parkinson's, the way that they speak is very different. The tone is very monotonous, a lot less energy in the voice. And voice science has existed for 30 years, 40 years. We knew about these cues early on, okay? And if speech pathologists are in the room, you know that we've been studying that for decades. What's really changed is that now there's technology with artificial intelligence that can help us analyze lots of data faster. And it's good for you guys and it's good for us, because before, the only people interested in voice issues were speech pathologists and laryngologists, right? And it was really, really hard to get attention from the scientific community, from, funding. But now, because all these tech guys are getting interested in what we can do with voice biomarker, it's actually a great chance for us to be able to advocate for voice disorders and to be able to get resources. And resources is money, right? Why can we cure breast cancer now so easily? Because 20 years ago, there was so much advocacy around breast cancer. Tons of money got, funded to help breast cancer research. And now 20 years later, we cure so much breast cancer. So the reason research is behind, is not because there's no research to do. It's because there's a lack of funding and interest. And that's why Kim and all the organizations here, you guys are making such a difference advocating for this disorder, because that's what's going to make a difference.
And can you talk about some of the different stakeholders you've brought together to make this move forward?
Yes. So I run this big project funded by the NIH called Voice as a Biomarker of Health. And we involve multiple stakeholders at the table, because to integrate innovation, you just don't have to make innovation, right? To make a tech doesn't mean that people are going to use it. So we need bioethicists, we need tech developers, we need clinicians, we need scientists, but specifically we need you guys, right? We need the patients. One of the fun facts that I always love to tell about, and Elijah here is going to talk about what we did and tested our technology. We have an app to record voice with a record button. And when we tried it, 80% of people didn't press on the record button. Okay? So people develop technologies. If you guys don't use it, or if you have no interest in using it, or if you tell the technology developers, hey, you thought I needed this, but actually that's not what I need, right? I need ABC. I need a product to make this. So that's the problem with, innovation and integration of innovation. And that's what I did my master's in at the University of Toronto. You have to have the needs driven by the patients, not by the tech developers or by the clinicians. Clinicians think they know what you need. We don't know what you need. You know what you need, right? So you guys need to have a place at the table in these big projects where you have to say, well, this is something that I would need. This is a product that I would need. We had a really fun activity at the conference. It was called Patient Challenges. So we had a real patient record their issues. One of them said, well, I'm a lawyer. I have laryngeal tremor. It's really hard for me, and I'm going to have to retire early because I want to have my mean lawyer voice. And I don't seem as mean as the other lawyer because of my tremor. And then people in the room were in teams and had to make solutions. And then they pitched their solution to judges, and they came up with really interesting ideas, So that's what we have to do. We have to have a starting point coming from the needs of the patient instead of clinician or tech-driven.
And so challenges, diagnostic challenges. So obviously AI can help us with that, but what are some of the challenges that you see right now with the way diagnosis is done for voice disorders?
So what's the gold standard to diagnose laryngeal dystonia? Do you guys know? Anyone? Video? Actually, not quite. It's a hearing, right? So there's no CT scan to diagnose it. There's no blood test to diagnose it. There's no specific questionnaire that's validated to diagnose it. It's subjective listening from experts. Okay? So that's a big challenge. And there's this fantastic paper that I didn't know you guys funded, but now you told me about it. There's fantastic paper from Al Maradi and a big group of laryngologists that's about 5 to 10 years old. where they looked at lots of different laryngologists in the United States and made them listen to voices of laryngeal dystonias, adductor, abductor, and laryngeal tremor and muscle tension dysphonia, and they had to give a diagnosis. And they didn't even agree. It was like 50% agreement. It was crazy. And that's our gold standard. So it's really hard to find the correct treatment if we can't even agree within the best experts on the actual diagnosis. So that's a big challenge.
And so diagnosis challenges lead to treatment challenges.
Correct. So treatment challenges, the treatment we have right now is Botox. But as Dr. Abdelhadi explained really well, it's not a larynx problem, it's a brain problem, right? So that's hard. Plus, what makes me really mad is sometimes the lack of humility of the clinicians, okay? When your Botox doesn't work, it's not your fault, right? It's not your disease fault. And often as a young clinician, I hear patients a lot coming to my clinic and say, well, oh, my doctor says that, my disease is too severe, Botox doesn't work, or I didn't do something properly, And I always tell patients, it's possible, but before blaming the patient or blaming the disease, look at yourself. It's a difficult technique. It's very precise. We do it half blind most of the time, right? So don't blame the patients, right? And that's one of the challenges. So one of the thing that I would love to start working on is a device where we could, we know with artificial intelligence if we're in or not. When I inject, I would love somebody to say, beep, beep, you're in, thank you, So I think that's technology. Is it easy to develop? It's not hard. We just need the money to develop it, the right partners to develop it. And that would be so amazing for all of you, right? So that even young people starting can have a beep, beep guidance. And that would change a lot, in my opinion.
And what are your thoughts about future treatments that are being developed?
So who knows somebody who's had a DBS implant here for Parkinson or... Okay. How is your experience with that? Has it changed their life? Not for voice, for Parkinson or for... Okay. It helped her voice or it helped her tremor? Voice. Okay, interesting. Who has seen one for Parkinson's? And has it helped them? So I'm so impressed by this technology. It's like one of the coolest technology that exists, right? Patients are like this and they turn their DBS on and they're like, okay. So I think that's a lot of the future of this field. And there's also guided ultrasound now that we do for Parkinson that's a little bit less risky and less invasive. We just have to continue to invest in that. Right now at our center, what we do is we find patients that have both hand tremor and laryngeal tremor to send them for that treatment, because there's not enough evidence on how it helps laryngeal tremor yet, because there's just not been any research. It's not because it doesn't work. It's because people are not putting the money for the research in it because it's too much of a rare disease. But I'm very excited about that because I think that we're going to find something.
And also there's a new toxin that's being tested called Daxxify. Any thoughts on that?
So I'm excited about Daxxify. Do you guys know about Daxxify by raise of hand? Good. So Daxxify is a type of Botox that's supposed to last longer, so 6 to 8 months instead of 3 months. If it were true and if it really worked, that could be life-changing for a lot of people. And I know that Dysphonia International funded a trial by Dr. Rosen at UCSF that's ongoing, where they're seeing if that makes a difference in treatment. And I think that in about a year or two, probably we'll have good information about that. I'm excited to use it. I'm always excited to use new things, and it could make a big difference. Imagine if you had to go, once a year instead of 3 times a year.
Do you have any ideas of what you would like to see as like the ideal treatment?
I really want my beep beep machine. I think that a lot of what I hear from my patients is they're stressed because they often drive for an hour and they don't know if that time it's going to work or not, and they don't know how it's going to work. The variability in their treatment, if I told all of you could get the same response at every 3 months guaranteed, who would feel better about getting Botox treatment, right? So sometimes Botox is frustrating, not because of how it works, it's because of the variability and the variability, again, is not because of the Botox, okay? Don't believe people that tell you that. It's really rare that it's because of the Botox. People get Botox in their forehead. I get Botox in my forehead, okay? It works the same every time, If I use the same dose, it's the same every time. So yes, there are scientifically proven responses to Botox where people have this habituation, for example, and you have to use higher doses. But have you ever heard about somebody going to get aesthetic Botox and telling you like, oh, my rhytids are still there. I still have wrinkles because Botox doesn't work on me anymore? No, right? So why do we make patients with spasmodic dysphonia believe the same? Is the Botox has the same effect every time? That's my frustration.
Well, and this kind of feeds into it because I was going to ask also, what are some of the biggest complaints you get from people living with voice conditions?
I mean, it's extremely frustrating, right? To not be understood, to not be heard, to not be knowing, to not be able to count on your voice, right? So like, I trust my feet to take me to where I need to. I trust my voice to communicate. And patients with voice disorders cannot trust their voice anymore, right? And whether it's laryngeal dystonia or vocal cord paralysis or other laryngeal cancer, they can't be sure of what their voice is going to sound like in the morning, and that causes a lot of distress.
What do you think is going to take to build the momentum to advance research?
It's going to take you guys, right? It's going to take patients. A lot of the research needs to be driven by the patients. You got to use your voice, pun intended, I guess. But you got to use your voice to advocate because that's what makes big changes in research. In subglottic stenosis, we've seen it. Who knows what subglottic stenosis is? It's a disease where people have scar tissue in their airway and they can't breathe. It's really bad. And they created a Facebook group of 8,000 people around the world. And they're driving the research. And it's beautiful to see. And we need that. And of course, your work is so important. But we need to hear more. You need to hear more. And the fact that AI is here is great. Use AI, use your voice to say, well, we can make a difference in that field.
And what are you most excited about with the research?
That's a big question. I mean, I'm excited that we live in an era where technology is here and it moves so fast that I think big changes can happen fast if we want them to and if we have the right players, right? Things are happening way faster than before. So I feel really lucky to live in that era where we could see the rapid area of change. We just have to put our resources where our mouth is.
So I'm going to actually ask you to tell a little story that you told before about how technology and AI can help patients. And the story of your patient with WISP.
Oh, yes. We have Joris in the room. So who knows about the WISP technology? Good. Did you already talk, Joris, or not yet?
Not yet.
Doing okay. And I have no financial relationship with Joris, just so you know, old person, I love relationships, so don't worry. But I met Joris and his company about 2 months ago online, and after Kim told me about them, and they have an app where it changes your voice to a voice that's amplified or optimized when you're communicating on the phone with your loved ones. So I've been offering it to my patients. And not even a week ago on Tuesday, I have a patient with laryngeal cancer. He has almost zero voice. He came to me with almost zero voice because of his cancer. And I operated on him. And after the surgery, I went to his wife. I always say, well, the surgery went well. This is how it went. And she said, Dr. Bensoussan, thank you so much for introducing us to this technology. He's been using it for a month, and it works so well that his mom, when he calls him, thinks he's cured. So there is technology out there, right? And we need these partnerships between the technology developer and the patients and the clinicians, because we have to tell our patients about it, right? I try to always, sometimes, and it's hard because, healthcare asks us to see many patients as much as we can. So sometimes what I'll do is I'll ask my speech pathologist to book a full hour with my patient just to talk about the technology and assistive technology options that are available for communication, right? And we say, okay, like that's a full, we call it therapy session, but it's really about presenting you with the right, what exists, how can we use it, how can we integrate it? Because just telling you, well, this exists is hard. You have to accompany the patient in their journey for that.
Should we open it up for some questions?
Yes, of course.
I had my tonsils out at 12. Oh, thank you. And ever since then, my voice comes and goes. And as I'm aging, we all are, it goes more frequently than it used to. I was diagnosed over 30 years ago, and I'm going later this month to be retested because no one's ever retested me to see if I was diagnosed properly in the beginning. So from what you said earlier, when I get to the doctor, if I'm having a good voice day, is she going to be able to tell anything? Or would I be better asking if I can book it as an emergency when my voice breaks?
That's a great question. I think that's one of the things that also frustrates me if Kim was asking me what frustrates me. Right now with our current care, we can only see you when you come to our office, right? So remote evaluation, remote diagnosis is going to have to take a bigger place in our lives, right? You can't only be assessed when you come to the doctor. So first of all, what I would say, without a specific app, just record yourself, right? So I always tell my patients when I do Botox, I say, whenever your voice changes, whether it's bad or not bad, record it. And now with our phone, you don't even have to write the date. The date is already there, right? So record yourself. Bring all kinds of videos or audios of recording for your provider. But with aging, our vocal cords get thinner and less reliable. So that's just a normal aging.
Hi. I was diagnosed with, I always get it backwards, the rare one, and
abductor
and muscle tension. But I thought it was in my mind. My husband, I would always laugh. I would say, drink a glass of wine, I'm a little bit more relaxed, and it kind of helped. And this is a lighter question. When it was brought up earlier today, as compared to, trying to get medications to kind of mimic. So I'm interested, what is the active thing that you're looking for or that's in Botox that kind of relates to plenty drinking wine that's actually helping with SD?
With any, yeah. So first of all, what you said, we hear a lot of people saying it's all in your mind. So functional disorders don't mean it's in your mind, okay? Like muscle tension dysphonia is called a functional disorder. It doesn't mean it's in your mind. So I'm going to share something personal. For a year almost now, since October 7, I've had twitches in my elbow every 5 seconds, okay? It's functional. It's not in my head. I mean, I have it every 5 seconds. You could measure it. It's definitely induced by what happened and the stress, but it's not, I can't control it. And I've had tests in neurology and they told me I don't have anything dangerous, but they call it functional. So that's really important to understand. Functional disorders doesn't mean it's in your head. It means that doctors are stupid enough to not have found a solution yet. Okay, idiopathic or functional is not, it doesn't mean in your head. It's your body is not working. Why do we get better when we're relaxed? I mean, Botox just forces your muscle to relax. There's other toxins that forces your muscle to relax. Alcohol does, right? Releases toxin that relaxes all your muscles. So it's kind of the same principle. We can tell our patients to drink. That would be really bad. But there are other things like I have, my patients with severe muscle tension dysphonia, I have sometimes them do muscle relaxants to see if that helps. And it also helps me in the diagnosis because, again, diagnosis is not perfect. So if my patients get better with muscle relaxants, then I know that it could be muscle tension dysphonia when I help them release that tension.
It's about in 2017, I was diagnosed with AB and MT, as well as in like 19, I have cervical. Is there a correlation between all those? And I like Botox has not been successful for me. And would you recommend I again?
Yeah, so that's a great question. So there is like research, official publication scientifically, and there's what we know from our experience, right? So, I mean, cervical dystonia, of course, is correlated to laryngeal dystonia. A lot of people with laryngeal dystonia will have cervical dystonia as well. It's a type of dystonia. When you think about it, it's really weird that only like abductor spasmodic dysphonia is only one tiny muscle that big in your whole body. You know, like, does it make sense that there's a disease affecting this one tiny muscle in your whole body? Not really. But no one's thinking like this, right? Like, no one's like question, like, how is it that there's just one little muscle? So it's really, there's a lot more cervical dystonias associated. And I could tell you that often when I see my patients with spasmodic dysphonia, they'll have sometimes a little head tremor, undiagnosed. And I say, have you seen that? And the problem with this is because the people who treat laryngeal dystonia and the people who treat cervical dystonia are different. That's a problem, right?
I came from Emory.
Yeah.
I worked Dr. Klein.
Yeah, he's fantastic.
Referred me to Dr. Jenna, so they worked together.
Dr. Chetta.
Mm-hmm. Mm-hmm. And so, I was fortunate at that.
Yeah, they're both great. But what we've done at USF, and because of our frustration of people treating cervical dystonia and laryngeal dystonia, so cervical dystonia are treated by neurologists, where the laryngeal dystonia is treated by laryngologists. So we've created a clinic called Laryngology Clinic, where we have once a month a laryngologist and a neurologist that can treat you together, because it's the same disease, it's the same. So it doesn't make any sense to treat it separately or to come for your Botox injection separately. And I mean, we've done only 3 up to now. It's our 3rd month, and we learned so much from each other. It's pretty amazing, right? So I think that is where the future is. You have, if I can give you feedback on how you sound, you definitely have a voice disorder. It sounds like a dystonia, whether it's ABD or and it's pretty consistent every time you speak. So I would try Botox again with somebody that's willing to, try different techniques until you can find something that works.
Taking new patients?
I am. We are, but this is not a sales pitch. We are.
Well, question for you on the injection of Botox. We've talked about going through the neck or doing the scope, and you say a lot of times doctors are going in blind because of the neck. I opt to have mine always done through the scope because I don't want that blind part. I want to know we're hitting it. How come that through the neck has become so popular with, that there's that blind option to it?
So I would say it's half blind. We do have the signal from the EMG. I think the difference is, and we spoke about that with Charles yesterday, laryngologists who were experts in Botox, like 20 years ago, there was 2 of them. Okay? That's all they did all day. They were very good. They were extremely precise. And obviously, the more you do, the more you're good at it. And it was kind of their Blitzer, it was his expertise. I mean, that's all he did all day. And now, thankfully, they trained a lot of people who trained a lot of people. But now there's so many laryngologists out there, right? There's a lot of variation in how we're trained and how much Botox we do. So although it's the same technique that he developed, he was really good at it. And, some people with 30 years experience, some people even do it without the EMG. Yeah. Have you ever had somebody do it without the EMG? Yeah. They call it touch. And I believe that if you're very, very, very experienced, you can do it the same way that, like, I do a lot of vocal cord injections with the needle. I know where I am. Sometimes the view is not perfect, and I can, I'm good at it because I do about 200 a year. But it takes a lot of practice. So I think your question is, why are we still doing that? Some people are switching. I know, Dr. Chetta, for example, I know he likes to do them a lot with scope guidance. I know in Asia, they like to do it a lot with scope guidance. So it depends. But I mean, if your doctor has a lot of experience and very successful with EMG, I would continue to do it with EMG because he's really good at it. right? So yeah, does that answer your question a little bit? It's still a very good technique, but if you're going to see a really young laryngologist who just started and you notice that your Botox is not as efficient, it's probably because he's missing, and you probably should ask to have a scope done at least until you find the right dose.
Do you know if there's anything in development as far as like mapping what's happening neurologically, like the signals that are being sent to the brain? So there is technology that's...
Yes. So Dr. Simonian is at Harvard. She's fantastic. She's a ENT surgeon, but because she came from another country, she could never practice. So she's dedicated her scientific research to just understanding the mapping of the brain and laryngeal dystonia. So she uses AI and brain imaging. So you should look into her work. She's really fantastic, and I think she's going to make a big difference in our...
What's her name again?
Dr. Simonian, Simonyan, and she works at Harvard, Mass Pioneer. Perfect.
Oh, well, just to add to that, do you think like after something like that gets, I guess, more fully developed, it would be easier for you to pinpoint maybe like where the Botox needs to go, or if it's needed at all?
Yeah, to develop techniques that are more precise, right? Or maybe an implant that would release the Botox. I don't know, instead of you having to, now we're working a lot with implant technology, maybe an implant that'll release Botox every 3 months with different doses. I mean, sky's the limit in terms of technology when we have the money to develop it.
Does that seem far away, or?
It depends. If you give people $100 million to find a solution, let me tell you that they'll find it.
Hi. I was diagnosed with essential tremor and spasmodic dystonia. That was about 3 years ago. I haven't had any Botox, only because I'm a baby, I'm scared, and the thought of a needle in your throat sounds painful. So I've sort of been living with this, and I guess my question is, will it get worse without Botox, or should I just suck it up and do it and just...
It's a great question. So the question is, is it going to get worse? Obviously, the clinicians are not God. We don't know. What we know is that, as Dr. Abdelhadi explained with essential tremor, as you age, sometimes your vocal cords get thinner, and the more thin they are, the more the tremor is audible. So that's a possibility, but it's not because you do Botox that it's a protective effect. Does that make sense?
Yeah.
So not doing Botox now doesn't prevent, there's nothing we do to prevent the disease to continue, so you don't have to have any regrets. Yeah. I mean, our patients, with numbing, I do numbing. Not everybody does numbing, but I numb my patients, and they tolerate it very well.
And the side effects, I think I've heard like some horror stories, or...
What horror stories?
Well, I read that some people have trouble swallowing, eating, even drinking water is...
Yeah, so if you start with a really high dose, you can cause, a lot of weakness of the muscle, and then it could cause trouble swallowing. We're very careful. If I have a 92-year-old lady with a really soft voice, I'm not going to start with 2.5 units of Botox. That'd be really stupid. So we're very careful. But as long, I always say it's a long-term relationship. Don't go to a provider, do it once, and then if it doesn't work, go to the next provider, do it once, and then in my book, it takes 3 times to get the right dose, right? Because you start small, then you up a little, then you make sure you can get the same result at the same time.
Okay, thank you.
Last question.
When I was leaving my Botox clinic, I met a woman who just had her injection that didn't work well either. She's convinced that it's not necessarily the surgeon, but it's the neurologist reading the EMG, and you've never mentioned any of that. How important is it to make sure you have a good neurologist, and how do you know?
It's a great question. So in most of laryngologists, we don't use neurologists to read the EMG. So, I mean, if you have a clinic where there's a neurologist reading your EMG with your laryngologist, it's amazing. Usually we read it ourselves, or we have our assistants, our speech pathologists with us and telling us like, oh, the signal's better. So, I mean, yeah, it's whoever's reading it, absolutely may be making a mistake, right? Sometimes the signal tells you if you're in a muscle or not, but you can be in the wrong muscle and it still gives you the right signal. That's why we need the beep beep machine. Thank you so much, guys.